Good evening, ladies and gents, and welcome to a seminar today, or talk rather, on neurointensive care and acute brain injury by Dr. Manni Waraich. Dr. Waraich, it's an absolute pleasure to welcome you to BrainBook today. And just for the purposes of kind of introducing you to people who may not know who you are, the very few people that that don't know. But Dr. Waraich is a consultant in neurocritical care and neuroanesthesia, located at the National Hospital, also known as Queen Square, in London, one of the leading centres for neurological care in the world. Dr. Waraich brings a huge wealth of experience, having previously worked at Southampton's Neurosciences ICU, but also has a huge range of interests spanning the likes of acute brain injury, subarachnoid hemorrhage, advanced neuromonitoring, and also point-of-care ultrasound. And it's probably important to know that Dr. Waraich is actually the national lead for Fusic Brain, which is absolutely incredible. And beyond the clinical work, Dr. Waraich is also a passionate advocate for leadership and equality in intensive care, and is actually a founding member of the Women in Intensive Care Committee at the Faculty of Intensive Care Medicine. With that, she also has a business diploma from Warwick and has experience in mergers and acquisitions in Sydney. So ultimately has a very unique combination of clinical excellence, leadership, and entrepreneurial insight, all whilst raising two incredibly accomplished daughters. So Dr. Waraich, thanks so much for joining us today. We're absolutely thrilled to have you here to talk all things acute brain injury and neurointensive care.
Thank you so much, and thank you for the invitation, and thank you, BrainBook, for asking me to talk. I am really excited, and yes, I have lots of passions, and brain injury is one of them. So I've been asked to talk about the role of neurocritical care and acute brain injury, and yes, as alluded to, I do have an interest in point of care and neuromonitoring. So hopefully I'm going to give you a little bit of a flavour of both, and at the end, the last couple of slides about where I think the future of neurocritical care is, with some exciting stuff at the end. So, big question, do neurocritical care units improve outcomes for brain injured patients? Well, yes, we'd like to think so. And we know from trauma networks, with the establishment of trauma networks in the UK, that actually trauma care has improved. So Centre TBI and all the big acute brain injury TBI studies do show that neurocritical care units do improve, and it is not just because of the intensivists and the neurosurgeons, but actually it's that whole MDT work. And like anything where you have expertise and experience, you need volume, and this is why trauma units work. And you've got two models really. You've got, you know, the model in the States where you have large neurocritical care centres, but you've got smaller units that will maybe do one or two coilings or aneurysm clip-ins and maybe some TBI. And then you've got Europe, which does have dedicated neurocritical care units. So this new protocol that's coming out is looking at those models of care. And even within the UK, we've got dedicated neurocritical care units. So I've been lucky to have been consultant in two of them and actually train another two. But there is also that hybrid model of having pods within a bigger general ICU of maybe about, 100, 200 beds. So that I'm really excited to see what comes out of this. But personally, I think that neurocritical care units do improve outcomes for brain injured patients. So what do we actually do on neurocritical care? We can't do anything about the primary injury. What we do focus on is preventing secondary injury. And so how do we prevent secondary injury? Well, it's pretty simple. It's the physiology. We're maintaining cerebral perfusion and we're maintaining cerebral oxygenation. And before, there was very little on brain tissue oxygenation, but with brain tissue oxygenation monitors, there's a lot more evidence for that. So there's a couple of really good studies looking at short-term hypoxia on cerebral metabolism. This is a Belgium study. And actually they said that normobaric hyperoxia may improve cerebral metabolic disturbances. They actually looked at lactate values through microdialysis. They had about 311 patients. They looked at lactate to pyruvate ratios. And actually they found that hyperoxia, normobaric hyperoxia, may improve metabolic disturbances. And you can see some of that literature also in out-of-hospital cardiac arrest, where there is some small evidence of hyperbaric oxygenation on out-of-hospital cardiac arrest. But then you've got ARI on the other side going, well, hyperoxia, maybe it isn't, maybe there are worse outcomes, and this is from centre TBI. But then you have to remember that the centre TBI patients, maybe the increased oxygen requirement and the hyperoxia that you're given at scene and pre-hospital is an indication of how severe the injury is. So it could be lung contusions or cardiac injury or hemorrhagic shock that's needing that increased oxygen requirement. But what we do know is that the BOOST 2 trial looked at ICP versus ICP and brain tissue oxygenation. And actually, they did find that ICP and brain tissue oxygenation improved outcomes in TBI patients. So this is their algorithm. So I have to just talk a little bit about brain tissue oxygenation. It's in millimeters of mercury, and you wonder, where's that figure come from? That's actually the partial pressure of oxygen in a brain cell. And if you think about it, all that physiology that you learned way back when, that happens to be the partial pressure of oxygen in a mitochondria that needs, which is 0.5 kilopascal, and that's needed to produce ATP to maintain cell wall stability. So that's where that magic 20 comes from. So if you've got poor brain tissue oxygenation, but your ICPs are fine, then what do you do? So on neurocritical care, what we do is increase the inspired oxygen and also increase ventilation through PEEP. And also the other bit of that equation would be increasing oxygen delivery. So we know from recent trials and recent studies, so the TRAIN one that came out not too long ago, looking at the optimum hemoglobin for acute brain injury. And it's something between 8 and 10, and we're now stuck on 9 at the middle. So unlike general ICU, where they will accept a hemoglobin of 7, brain injury patients, we do know that brain tissue oxygenation is as important as brain perfusion. So we're looking at PO2s, PbO2s over 20. That gives you, so partial pressure arterial from your blood gas, 10 to 13 kilopascals. And we're looking at hemoglobins of 9. And we actually use this algorithm not only in TBIs, but also in subarachnoids. So we've taken that research and put it into subarachnoids, because we also know that DCI, or delayed cerebral ischemia from subarachnoid, has a similar inflammatory pathology as TBI. And I'm luckily in a centre where we use brain tissue oxygenation for subarachnoids. And again, better outcomes if we're using brain tissue oxygenation, especially with novel therapies for vasospasm like milnarone, which is a cerebral vasodilator. It again, you're not just relying on hypertension, because we know that hypertension can cause hyperemia, and that will just increase ICP. And if you've got that hyperemia in a brain that's not auto-regulated, then that's a worse outcome. So I'm going to go back to perfusion, because it isn't just CPP 60 to 70 as per Brain Trauma Foundation guidelines. As I've hinted, there is something that happens with autoregulation. So if you're autoregulating normally, if there's an increase in MAP, you're going to get vasoconstriction to reduce cerebral blood flow. And the opposite, if there's a decrease in MAP, there's vasodilatation to increase cerebral blood flow. So there's a MAP and ICP vary in opposite directions. So you should get a positive PRX, a negative PRX if you're autoregulated. However, we know in an injured brain that autoregulation may be disturbed. So and we've seen this in brain injured patients, that as you increase the MAP, so you increase the cerebral perfusion, actually it causes an increase in ICP. So you almost get a linear. So unlike that CPP opt graph where the optimum CPP is the figure down at the bottom, we're getting a linear approach. And I did a case not too long ago where actually a very patient with a severe subarachnoid actually her optimum CPP happened to be about 40 because that was the only time her ICP was below 20. So autoregulation is coming in. So we're not just relying on fixed figures, we're looking at autoregulation or the lack of. And you'll know in Brain Trauma Foundation guidelines now, there is that little bit about map challenging. If you find that the ICPs are still high, can you do a map challenge? But if the ICPs go up, that's a brain that's not autoregulated. So don't increase the blood pressure any further because you will just get hyperemia and raised ICP. The rest of the talk, I'm actually going to talk about neuromonitoring because that's the other big thing in neurocritical care. So we do a lot of neuromonitoring to be able to optimize the perfusion and the oxygenation, but also to give us, because it's quite difficult just to go down for scans every 2 minutes. This is a beautiful infographic from Arti Saravar, who did a great review article on neuromonitoring in critically ill patients, because we're not just talking about neurocritical care and TBIs, we're also talking about cerebral dysfunction in other critically unwell patients, so septic encephalopathy, hepatic encephalopathy, preeclampsia. There's a whole range of pathologies where, we should be looking at monitoring the brain as well. I think we've always monitored the heart really well in critical care. And there is now a trend, and especially with point of care ultrasound, looking at monitoring the brain as much as we monitor the heart, because it is optimizing. And we know from COVID, where we had lots of dysexecutive syndrome, lots of neurological manifestations of COVID, there has again been an increase in looking at what could we have done to optimize brain health or brain perfusion during those stages. So the most popular one is optic nerve sheath. People love putting a probe on an eye. This is, it's easy. Everyone thinks it's easy. And it is. It's a pretty easy point of care examination. The optic nerve sheath itself is a continuation of the dura, and it contains the subarachnoid space. So if you get any rapid rises in intracranial pressure, that's transmitted through the subarachnoid space, causing distension of the optic nerve sheath. They did a lot of work with cadaveric models and autopsy models to have a look at the diameter of the optic nerve sheath. As you go through the studies, there's varying figures that are banded about what is the optic nerve sheath diameter, the normal optic nerve sheath diameter. And remember, old ultrasound machines didn't have the resolution to be able to do that. So with newer ultrasound machines and with better MRIs, we've actually settled on that the optic nerve sheath greater than 5.8 millimeters is an indication that there's raised ICP. There's obviously age differences, so the optic nerve sheath diameter in a pediatric population is completely different. So this is an ultrasound picture of what an optic nerve sheath looks like. So you've got a hyperechoic structure in the middle, which is the optic nerve. And then you've got some hypoechoic bands, hyperechoic, so the dark bands either side. So you've got a white band outside of the optic nerve, and then a dark band again. And then this is a recent consensus on where do we measure? Because again, that was a bit of causing confusion on how to measure the optic nerve sheath. And it's actually the inner edge of the hyperechoic band, or the just where that dark band ends, not the absolute outside. So that is international consensus now. We're measuring the inner edge of the hyperechoic band. So anything above 5.6, 5.8 millimeters is probably indicative of raised intracranial pressure. Then you remember I said at the beginning, it has to be a sudden rise. There is a distensibility to the optic nerve sheath. And we know from cadaver models that beyond 8 millimeter, optic nerve sheath beyond 8 millimeters, there is lack of that elastic recoil. So if we look at pathology like subarachnoid aneurysms, where they rupture, there's a sudden rise in ICP to about 45 and 50. And those are the poor grade subarachnoids, the grade 5 subarachnoids. that die instantly, that if you measure the optic nerve sheath in them, it is going to be enlarged. But because of the lack of the loss of elasticity and recoil, that optic nerve sheath doesn't go down. There's lots of research going on now about, can you use the recoil of the optic nerve sheath as a measure of reducing ICP? I'm a little bit wary of that because I think optic nerve sheath is quite prone to artifact. And I'm going to show you an example of that in a second. But I'm going to just jump onto this slide first about physiology and what happens to a typical MCA waveform. So the brain, luckily, is a low resistance organ, so it gets flow both in the systolic and diastolic phase. And because of that, if you put a probe on and do a pulse wave Doppler across the middle cerebral artery, you will get this sharp systolic upstroke and a diastolic step down. And as the intracranial pressure rises, you encroach on that diastolic flow. So you get reverse diastolic flow, and you almost approach, and that will reduce your cerebral perfusion pressure. Then you reach a critical closing pressure where the brain is only relying on systolic flow. And this is where that CPP comes in and that challenging, can you improve flow? So I'm going to show you an example that I've got as to what I think, why I think optic nerve sheath you have to use with a little bit of caution. You can get artifact from something called the lamina cabrosa, which is just behind the back of the globe, and it can give you those that hyperechoic and band appearance. So how do I know in my practice if I've got the true optic nerve sheath? There should be the central retinal artery running through the middle of it. So you measure, true measurement of the optic nerve sheath is 3 millimeters behind the globe. As I said, the inner edge of the hyperechoic, outer hyperechoic bands. And you can see on mine, I've got a distance, that's distance 2, is 0.59 centimeters. So just on that border of 0.58. So I'm looking at it, I've got a central retinal artery, and I've put a pulse wave Doppler over that central retinal artery. So I've got something that's upper limit of normal for suspicion of raised intracranial pressure. But by insulating the central retinal artery, I can see I've got that reverse diastolic flow. So I've now got two modalities to show me that this patient probably has raised intracranial pressure and is a vulnerable brain. So like optic nerve sheath, but you've got to be aware of the limitations of it. And also just adding this extra little bit reassures you that you've got a true measurement. So optic nerve sheath in the right hand has got a 90% sensitivity and an 84% specificity. Easy to learn, easy learning curve. You could probably learn within about 30 scans of doing it. And it's quite useful as a point of care measurement of ICP, pre-hospital, or just so that you know where you are. To make it even more specific and sensitive, and we know that the eyeball is not spherical, is you can look at the external, the eyeball transverse diameter, and that's usually between 24 to 27 millimeters, and we confirm that with MRI CT scans. So if you have a ratio of the optic nerve sheath diameter over the eyeball transverse diameter, that gives you a ratio, a normal ratio of 0.19. So if you've got high ICP, the optic nerve sheath diameter will increase, but your external transverse diameter will be the same. So you'll have a ratio greater than 0.19. Chiara Robber, who is a brilliant neuro-intensivist in Italy, she does a lot of point of care of ultrasound. She said her paper looks at two variables, best correlated parameters, and she actually insinuates the flow in the straight sinus venous system. And that's a really low flow system. So if you've got increased systolic flow in the straight sinus, and that's probably due to compression of the venous sinuses because of raised intracranial pressure, and you combine that with optic nerve sheath, so a raised systolic flow velocity in the straight sinus plus a raised optic nerve sheath, then that's probably giving you a higher predictor value for ICP than optic nerve sheath alone. This is also from Chiara's paper. She did a great review on how we should be using point of care ultrasound and optimizing using it as a pre-hospital or a neurocritical care to ascertain what's going on. So B mode is your standard grey-white picture, and then pulse wave is the colour that you can put on. So you can see, you can use it in hydrocephalus, and I know Mr. Watkins, who's the ex-president of the Hydrocephalus Society, he uses ultrasound when he's placing shunts. So there's increasing use of ultrasound even within neurosurgery. But in neurocritical care, it's a lot easier when you've got a little bone flap removed. There'll be 20% of the population that actually don't have an acoustic window, because there's very few landmarks that we can look at. So in B mode, we're looking for a temporal shelf at the other end, and then the sphenoid wing, petrous bone, and then some hyperechoic cerebral peduncles with brighter basal systems around it. And you can see there's lots of things that you can see. You can look at midline shift because the third ventricle is a really bright image on ultrasound. We can put pulse wave Doppler and look at velocities, MCA velocities for vasospasm by using the Lindergaard ratio. And just as it pointed out on those previous slides, looking at brains that are vulnerable because you've got that reverse flow. So approaching critical closing pressure and leading to cerebral circulatory arrest. So with the newer machines and with all of the with pulse wave Doppler, we can actually get an ICP value, so NICP, without actually having to put an ICP bolt in. So there's a Gosling formula. So pulsatility index is the systolic velocity minus the end diastolic velocity over a mean velocity. And it normally has a value up to 1.2. So a value greater than 1.2 is a marker of impaired cerebral perfusion. And that's because you're losing that diastolic velocity. So you've got a higher numerator over denominator. So a PI of 2.3 would indicate an ICP of 22. Other things that have come along in neuromonitoring is processed EEGs. We know that 15% of the ICU population with impaired consciousness with unclear causes probably are having non-convulsive seizures. And these non-convulsive seizures are obviously a metabolic burden on an already vulnerable brain. The new processed EEGs are non-invasive, they're usually in strips, and they use 4 frontal channels. And there are a lot of things with an algorithm that they process. So they will give you a density spectral array. And this is where we've taken stuff from anesthesia and put it into neurocritical care. So the anaesthetists are very used to using a processed EEG for depth of sedation and depth of anesthesia. So different anesthetic agents have different DSA pictures. So there's like blue, yellow, green. So ketamine has very much blue, propofol has yellow bands. But the other thing that the EEG will give you is a number. So you see the bright yellow numbers, 32, 82, 21. They're giving depth of sedation. Because as you get, as you're deeper asleep, you've got greater alpha and delta waves. And as you're waking up, you've got the high frequency gamma and beta waves. So a higher number means the patient's awake. A lower number means the patient's asleep. Well, we actually use the SED line, which is a 4-channel processed EEG in neurocritical care to monitor our sedations when we're looking at patients that are managed medically for raised ICP. I can tell you now, if you've got an EEG that says 0, there is no flow whatsoever or no electrical activity. And so you could use an EEG as a surrogate indicator of inadequate cerebral blood flow. So you know that the cerebral blood flow will decline to 40 mils. If it declines to about 40 mils per 100 grams per minute, the EEG loses the faster frequencies. So you get a very sort of low number and 0 if there is brain death. So it gives you lots of information about neuronal health as an endpoint of cerebral perfusion. and the algorithms are getting much better, and so is the equipment. Another thing that's come to the forefront in the last couple of years is pupillometry, and pupillary reflex is really basically nature's own ICP monitor. So we know with raised intracranial pressure, you get compression of the third nerve fibers as they reduce in the parasympathetic effect. So pupillometry measures the constriction velocity, the dilation velocity, and the latency. And again, to give you a little algorithm to give a number, and that's called the neurological pupil index, or NPI. So the normal NPI is 3 to 6, and that says the pupil is reactive and it's briskly reacting if it's 6. So an NPI less than 3, sluggish pupil reaction, NPI of 0, a non-reactive pupil. So you can start to look at, and they did this with the Orange study, that they did NPI for hourly from day 1 to day 7 in acute brain injury, and found that repeatedly abnormal values indicated poor outcome. The NOPE study, which is an Italian, French study, looked at API alone with TCDs, and again, using 2 modalities gives you a better idea to determine if you need to intervene. So if you've got, maybe if the ICP is the same, but you've got a change in NPI, maybe that's an indication to go for another scan. And if you've got another modality that you're using, so TCDs, and you're seeing that change in waveform, all of these monitors are just allowing us to see if there's a change. Because once a patient's asleep and sedated on neurocritical care, we've lost our gold standard of assessing a patient on neurocritical care, GCS. So we are having to rely on these surrogate monitors and markers to be able to help us. There's a few papers coming out now using pupillometry in prognostication for covert consciousness. And obviously pre-hospital, it'd be great if we could, rather than a pen torch, be able to look at if there's that slowing, that sluggish pupil as patients are being transferred to neuroscience centres. And I'm working with a company to try and build an app on a phone, because it's very difficult to measure pupils with a bulky machine if you're at the head end in an ambulance that's going at 80 miles an hour, not on the M25 because that's really slow, but hopefully trying to get to a neuroscience centre. This is a novel neuromonitor which hasn't quite taken off in the UK, and it slightly disproves the Monroe-Kelly doctrine, so all that stuff that we learned in the first year of med school in physiology. This is a Brazilian group. So the late Professor Mascaratas had normal pressure hydrocephalus and had a shunt. So he experimented on himself, and he found that there were micrometric beat by beat cranial expansion. So he worked out when his shunt was blocked because there was expansion of the cranial. So despite what we've been told that the skull is a fixed box, there is some expansion. So he demonstrated linear correlation between cranial microexpansion and increase in ICP. And of course, with AI and machine learning, they've managed to now put that. So Sergio Brazil has got a machine called B4C that looks at the ICP waveform. So you know that P1 is the percussion, P2 is your tidal, and P3 is the closure of the aortic valve. So the B4C monitor looks at P1 and P2 and gives you a P2 over P1 ratio, because you know when you lose that brain compliance, P2 is higher than P1. And it also gives the time to peak as well to assess that intracranial compliance. So that's indicating there's changes in volume and pressure. So they found that a P2 to P1 ratio of 1.2, which is pretty easy to remember because it's the same PI ratio, does suggest there's raised intracranial pressure. So the actual monitor is just a band that goes around the head and just measures those micro pressures. There's a similar product using tympanic sensors, which shows changes in ear pressure as changes in intracranial compliance as well. I'm going to, what do I hope that, hope to achieve by talking to neurosurgeons about neuromonitoring? there is definitely a move away from just an ICP number. So great bit of work coming out from Centre TBI over the last 3-4 years, looking at ICP burden. So Brain Trauma Foundation guidelines say that you shouldn't have to do anything above an ICP of 22. We're trying to move away from that. And this is with ICM, again, the software that they use, and lots of data points at Cambridge, and we have ICM software at Queen Square. And we're moving away from just that 22 as the absolute number of not doing anything. ICP burden is about how high is the ICP over what duration of time. So you can see on that graph, you can have an ICP of 25 for 30 minutes. That's not a high burden. But an ICP of 20 for 360 minutes is actually a greater burden. And this is where the non-invasive other parameters, the point of care ultrasound, with looking at the waveform. Because if I had a patient like this, I would look at the ICP, say if it was 22, I would look at the my waveform with the systolic spike and the diastolic step down, work out the PI. And even though the number might be 22, I might be able to see on my other monitors that the brain is vulnerable. And at that stage, I try to optimize. Are they having seizures? So I'd go back and look at the processed EEG. Is there evidence of seizure activity where there are spikes in the PSI, the patient sensitive index, indicating that even though the patient's sedated, they might be having seizures? Is there something I can do to optimize ventilation on the patient? Is there anything I can do to optimize their brain tissue oxygenation? Is there ways to optimize their hemoglobin? So when I'm using all of this in neurocritical care, I am just trying to reduce that ICP burden, because we do know that high ICPs will just cause critical closing pressure and cause brain ischemia. The last couple of slides, I'm going to talk about what's emerging in neurocritical care. So we know that in stroke patients, there's a lot of stroke leads to intestinal dysmobility and leakiness of the intestinal barrier. And there's a change in gut bacteria. And the way that stroke patient pathology could be improved in the future is looking at improving gut microbiota and maybe improving their rehab potential and neurological outcome. Other things that are coming through are points of care biomarkers. So Virginia Newcomb at Cambridge has got funding for a brains TBI using a point of care assay. So if you're at a sports event, using a simple point of care assay, or if you're in ED. Another thing that came out of Centre TBI was, again, moving away from this mild, moderate, severe brain injury. We know that brain injury itself is a huge economic burden on society. And actually where we can make the most impact is optimizing those patients with mild. So we're trying to move away from the mild, moderate, severe brain injury determined by GCS, but looking at other markers. So again, if we can have other things in ED, so Virginia's hoping to use 2 markers, GFAP and UCHL1, as biomarkers to triage patients. So say if you've got a patient that on the old system as a mild TBI, do you scan them? Do you optimize them? Those are the patients that probably need closer monitoring, making sure their blood pressures well maintained, they're oxygenating, their HB is normal, and just neuro-monitoring them with standard GCS. Those patients with, and maybe the biomarkers may help predict long-term problems as well. So some exciting work to be done on biomarkers. And obviously we have a lot of data in neurocritical care. You can just see how many monitors I have with brain tissue oxygenation, ICPs, CPP, EEG, CO2, And if we put that all into machine learning and AI, maybe it can help augment clinical decision making, because one of the hardest things in neurocritical care is that neuroprognostication. Can we use all the data that we've got to allow intensivists to make impactful decisions for patients for their care? Because time is brain. So can we optimize all the way through to reduce that secondary brain injury? And can we also use that in areas where there isn't the expertise of a neurocritical care physician, where it's not readily available? So can we use that in low resource countries to help outcomes of acute brain injury in areas where there isn't a neurocritical care? So it comes back to that first question. Is neurocritical care worth it? Do they improve outcomes? I think so. And I think it's a combination of all the monitoring that we have for secondary brain injury. But I also think ultimately it's the MDT work, and it is that expertise of everyone's experience coming together and just constantly looking at very time-sensitive information, but is that attention to detail of neurocritical care. And it's probably one of the reasons why I enjoy doing what I do. I'm going to stop sharing there, and hopefully I'm running to time as well. That's really good. Got time for questions.
Amazing. No, thank you so much, Dr. Waraich. I think we can all agree that was a really insightful talk. I mean, especially, you know, talking about kind of the core principles of neurocritical care, but then you kind of think, you know, where it can go as well. It's a very exciting part of intensive care medicine, and even, you know, you work very closely with neurosurgeons. What's exciting, I think, is even some of the things you mentioned, such as kind of the non-invasive monitoring. And I know there's kind of in America, they have these kind of Wendy headbands and all sorts of things which they're trying to use in kind of pre-hospital care to optimize the brain really before it gets to hospital. So just with that, just before we move on to some general questions, but what do you think are the most important early interventions can be done in a trauma setting? Let's say someone who's sustained a head injury in the community. What could be done in the first 10 to 15 minutes that you think can really optimize those later days and weeks on the unit?
Of course, yeah, great question. And I think, you know, I think there is this move away from, you know, what's done in neurocritical care. I think ultrasound has really revolutionized how we manage patients, and also trauma networks. So trauma networks and pre-hospital medicine. I think if you're putting a probe on to look at the heart to see if it's underfilled or contracting, it's the same probe, it's a phase array probe. So I think it is optimizing. I think it's identifying that you've got a brain that's vulnerable because you've lost that waveform. So you don't have to do numbers. You just have to put a probe on and see, okay, the middle cerebral artery is a pretty big artery. It's a good one to see, because that, you know, that's the one that's going to have the most devastating effect, isn't it, with pleasure. If you can see that there is a change in waveform, then there is a change in hemodynamics. So it's optimizing perfusion. So it is ensuring, and I know there is always that fight between, you know, ATLS and, you know, systolic of 90. God, you know, my heart dies every time they say systolic of 90, but it is improving. And, you know, with transfers now, they actually have, in ambulances, they have the head up. And even when they're doing with a Lucas and they're doing chest compressions, there's actually, you know, more. So slowly but surely we're getting there. You know, it's no longer about, you know, just maintaining perfusion to the heart, because ultimately the whole point about resuscitation is perfusion to brain, and people are aware of that. So if I can get everyone to do point of care ultrasound pre-hospital, or even an optic nerve sheath, just to see, does this patient have a vulnerable brain? Can I improve perfusion oxygenation?
No, absolutely. And I think it's so interesting. I mean, no matter how advanced you get, I mean, ultrasound really, as simple as it might be as a kind of imaging technique, it's incredible. I mean, you ask any cardiologist, that the one thing they'd always want is an ultrasound for echoes. And I think it's interesting that's not always the case in hospitals when you think about the brain. It's such an important organ, and ultrasound is such an easy thing to access. It's interesting how that's not already been kind of optimized it. So I'm really, you know, it's really exciting to see how somebody like yourself is really advocating for ultrasounds in intensive care, and especially when optimizing brain health. And I think it's a cheap bit of equipment that, you know, can ultimately, like you mentioned, change the trajectory of somebody's life, and that's really interesting.
And it comes back to that health economics, doesn't it? This is, you know, people with brain injuries, they're young, you know, the subarachnoids, the TBIs. And yes, we do have that, you know, second curve with the older, but, you know, taxpayers, carers for children, carers for their, you know, elderly, it's a large burden. And these are devastating injuries, they're life-changing injuries. So even if we can optimize, my old consultant, when I first started neuro ICU, said there's no point dragging someone out of the, you know, under a truck in the M3, you know, a 40-minute downtime GCS3. We know the outcome's not going to be good, because actually it's about rehab potential as well, isn't it? So if we can optimize everything, then we know. That's why the M score is so important now on ATLS. You know, what was the M score before you're intubated? If they're an M5, we know we can get back to an M5. That's a pretty good rehab potential. But if the M score was M1, M2 before intubating, there's very little rehab potential. And this is, again, where neurocritical care, you know, patients should go to neurocritical care, because it's the physios, it's the therapists, it's all of that trying to get, it's not just the neurocritical care bit, it's that rehab potential building on that as well.
No, absolutely, and yeah, it comes down to the basics, like you mentioned, because ultimately you can't prevent that primary brain injury, but what you most definitely can do is prevent that secondary brain injury, and I guess that's, you know, the pivotal role that you guys play, and that's why it's so important, I guess, like you mentioned, you know, neuro-intensive care units, kind of IC units focusing specifically on kind of the neurological aspect, because that's ultimately key to the patient's trajectory. There's another thing, Dr. Waraich, I just wanted to touch base with you, really something really exciting that you also mentioned about, which is kind of biomarkers. And I know biomarkers, I mean, you're looking in, for example, you know, with the heart and troponin, and you're seeing how it's kind of revolutionized acute cardiology and CCUs. And it's interesting with the brain as well, how there's not been a biomarker used as of yet, but I think there's been research into things such as kind of GFAP and NFL and UCHL1. What kind of use do you think they have? And do you think we'll reach a stage soon where we can probably have rapid blood draws and point of care devices even before the patients reach the ED?
Yeah, so this is what Virginia's doing from Cambridge, you know, working very closely with Baxter in producing point of care biomarkers, and GFAP, and definitely UCLH1 are the biomarkers that we've targeted. We use biomarkers all the time, brain biomarkers. So we use NSE regularly in, you know, neuroprognostication for out of hospital cardiac arrest. It is trying to get that. And for those of you who play rugby, that score for rugby to, you know, whether you need to stay on the pitch or not, you can fudge that, but you can't fudge a biomarker. And I think, again, the combination of having, you know, a rapid biomarker that just sort of changed the colour, you know, point of care ultrasound on the pitch. And, you know, as Chiara's saying, there's actually rapid changes with, you know, just a small head injury in a sporting field. You get, because of that high ICP, you get compression of the venous sinuses. You can see a change in velocity. So there's a huge thing. If I could have my way, if money was no object, but it always is, you know, we've mentioned cardiology quite a bit, and I know you're working in cardiology at the moment. If you look at cardiology and you look at neuro is about 20 years behind. So cardiology took off, as you said, you know, with cath labs, with interventional cardiology, you know, get to a cath lab quickly, open up the coronary vessel. And we can see that with mechanical thrombectomy, get to a stroke unit, get mechanical thrombectomy. And you can see with cardiology, they're very smart. They've got those shock network, heart network. If I had money, if I could get that 25 billion off Rachel Stevens, I would have a brain shock pathway. Because I think part of it is that you know, those of you that work in neuroscience centres, you accept a patient and they take 4.5 hours to get to a neuroscience centre. So either we go out as neurointensivists, neurosurgeons as a unit, and we go and do the intervention, bring back, retrieve, very much like they do for ECMO and PEDS. You know, we need to look at either we train everyone up to optimize or we retrieve into a neuroscience centre. But I agree with you, we need to be looking not when they get into the neuroscience centre, but at the point of injury, because second after the injury, start to optimize to prevent secondary injury.
No, absolutely, I agree with you. And I think it's so interesting how, you know, when it comes to, you know, the brain, it seems like there are a few things which might be lagging compared to the other specialties, just because, for example, like you mentioned about the kind of shock teams that you have at Brompton and Harefield when, and they go to the units or they go out as an outreach team, just like ECMO, and it's quite amazing what they do actually. And you think that level of care to be kind of as an outreach team to different hospitals is amazing. What do you think is stopping that from happening in let's say in neuro-intensive care or neurocritical care? Because I know that problem, even having spoken to neurosurgeons regularly about other things as well, let's say even with spinal issues like cord equina, it is a bit of an issue actually, that huge time period. And you think that 4 or 5 hours that the patient's sitting in ED, God knows how much irreversible neurological damage is being had. So why do you think that problem exists and it doesn't necessarily, we don't have that problem with other specialties? And what do you think we could do to change that?
I think it's education. I think, you know, it has to come through education. And we are moving that way as a neuroscience community, you know, moving away from neurocritical care and neuroscience is very much, neurocritical care is definitely a Cinderella. You know, we weren't involved in any of the trials because pregnant women and TBI patients excluded from every general ICU trial. We're starting to get neurospecific trials coming through that are looking at brain injury. So I think education, I think mechanical thrombectomy, you know, just the stroke awareness, the fast, you know, people are more aware that time is brain. And I think it just has to be education, not only within the neuroscience community, but also to the public as well. And you know, charities, you know, in the UK, we have the Brain and Pillar Charity and Dementia Research. So there is that growing understanding of, you know, the brain is as important as the heart. But I think just we are always going to be 20 years behind cardiac. But, you know, we're slowly getting there through trauma, recognition that brain perfusion is also as important as the orthopedic surgeon putting the X-fix on the fractured femur. No disrespect to my orthopedic colleagues.
No, and I think, no, completely right. And I'm really pleased that, you know, we are heading towards that direction. And I think you're right, even with stroke, I mean, how many years have we had the FAST trial, and even FAST, I think the acronym for FAST has now changed and they're including more stuff. So it's really good to say that, and I'm glad we are heading in that direction. I think we have a few questions in the chat. I think Nathan has a question. Nathan, you've written quite a bit. Do you want to maybe put your mic on and ask your question?
Don't be shy.
Nathan, are you still with us?
I think Nathan might have gone. I did see in the chat, he said, thank you.
Yeah, I'll read this question out. So it says,
yeah, of course, yeah.
Hi, Dr. Waraich, thank you very much for the insightful talk. So Nathan is a medical student with a growing interest in the cardiovascular complications that can follow a TBI.
Yeah.
He's particularly curious about your views on the use of beta blockers in this context. Have you found them helpful in preventing secondary brain injury or managing extracranial complications in your clinical practice? As far as I am aware, as far as he's aware, they're not yet universally recommended, but some studies suggest potential benefit. Do you think they have a role in routine management in the neuro ICU or pre-hospital setting?
We do know, and thank you, Nathan, for the question. And I know you've just put up, you're trying to get your mic to work. Very good question. We know that with that high ICP, there's a lot of other things. So years ago, no one would think about doing pituitary tests on a post-TBI patient. If you think of the pituitary stalk and you've got a high ICP, it's prone to ischemia in the stalk. And we haven't really quite got why we have such a dysregulation in the sympathetic system with acute brain injury. So do beta blockers work? Very good studies to show that, yes, early use of beta blockers in the TBI population does improve because you're dampening down that sympathetic activity. But if there is that increased sympathetic activity, that's also a marker of how severe the brain injury is because you've got that dysregulation. So there's two folds in it. You know, does it improve outcome? Or maybe we're picking patients where that dysregulation is quite a severe sign or a marker of how severe the injury can be. I have used beta blockers in my practice, but there's also the other, you know, having that sympathetic burden on the cardiac system, and which is why we're moving away from hypertension in delayed cerebral ischemia for subarachnoids. So I use a combination of beta blockers, and actually if you're looking at alpha blockers as well, so the less expensive clonidine, but dexmedetomidine, so a combination of alpha and beta blockade to reduce that down. And yes, maybe does help, but it's also, I'm always a bit worried, it's an indication of how severe the brain injury has been. Thank you for that question.
No, and thank you, Dr. for the answer. And it's, I think even when you factor in kind of the economic aspects, I mean, it's quite interesting to use beta blocker when you compare it, I guess, to the expensive ICU medications. It is fascinating to see how something like that, I guess, could potentially be used. But then again, like you mentioned, it can reflect maybe a poorer prognostic indicator in these patients in terms of how much brain injury they may have had. So it's really interesting. And we have another question as well from Sneehill. So he says, "Hi, Dr. Waraich, thank you for joining us today. He would like to ask about no-flow aspects of brain circulation regulation after mechanical thrombectomy."
Just going to clarify the question. Thank you for the question. So,
Sneehill, are you able to put your mic on and repeat your question?
Yeah, sure. Thank you for joining us today. And I would like to ask you regarding the no-flow theory, like in what ways it affects the brain regulation after mechanical thrombectomy we were talking about today.
No flow, so you mean no recannulization post-thrombectomy?
Not really. I have studied that we do mechanical thrombectomy in stroke patients.
Yep.
And after that, the circulation is not revived yet. So what could be the etiological background of this autoregulation being affected?
Apologies, I might just ask for a few more. So patients had a thrombectomy, but with a good ticky height, good, but no flow through the large vessel occlusion.
Yeah, absolutely. Like MCA, we can talk about.
Yeah, so thrombectomies are just large vessel occlusion. It would be MCA or Basler. And you've got the TICI outcome score. So TICI naught, no recannulization or no flow. So what would be the cause of a TICI naught?
Yeah, absolutely.
Useful to have CT perfusions at that stage.
Mm-hmm.
Quite a lot of stroke units use CT perfusion before going for a thrombectomy, just to ascertain. So CT perfusions give you a lovely view of what's reversible and what's irreversible. So if you've already got a patient, especially with posterior fossa strokes, because you can extend that thrombectomy time, but we know the posterior fossa is quite prone to ischemia because it's a small space. You can get infarction quite quickly. So those are the areas where you're not going to, thrombectomy is not going to help. It's not going to give you flow because it's already infarcted. During COVID, we saw a lot of increased clot burden. So we had large clots, and definitely with an inflammatory, infective purpose, you can get a clot that just sort of extends ICA to MCA.
Yeah,
and that is
absolutely.
and that would be it. It's clot burden. The other reason, you may get some partial recanalization, but if a clot's in the M2 section of the MCA, the further you go, the more likely you are to get risk of rupture of the MCA vessel. So radiologists will only ever do good aspects on an M1 large vessel occlusion, and basilar, before they attempt a basilar, they will do a CT perfusion to ensure that there isn't already ischemia. Basilar artery and vertebral artery, again, prone to rupture. So even if we have a patient with a subarachnoid that's got posterior fossa vasospasm, basilar artery, vertebral artery, our radiologists are really reluctant to go up and do angioplasty because it can be quite friable. Remember, thrombectomy patients tend to be elderly, so their vessels are already friable. So it is that lack of collateral and lack of and just lack of collateral flow that gives you that no flow as well, but clot burden. So something else is happening with that stroke. Thank you for that.
Okay, thank you. Thank
Maybe
you very
think a
much.
little bit on that one.
Okay, it's okay.
Guys, do you have any further questions? Get them in quickly. Just whilst we're waiting for find a couple of questions, Dr. Waraich, there's something I wanted to ask you as well. And what do you think of kind of things such as I think there's some data sent by some of our colleagues in Cambridge are working on some things, and there's something called I think the Liverpool HIT score or something in kind of TBIs and triaging stuff. What do you make of some of these new triaging tools, and do you think any of them could actually maybe, let's say, serve a long time in clinical practice? I think there's some interesting data put out recently.
I think so. I think GCS, we had the anniversary of GCS last year, and it's a great score, but it was meant for distinguishing alcoholics intoxication from a brain injury in Glasgow. And it's fascinating how they came up with the score. It's a really good score. It is a very crude score, and as we pointed out, whether it's mild, moderate, or severe, a brain injury is a brain injury. And actually, you're going to make the greatest impact on someone with a mild, what used to be classified mild, that GCS, 13 to 15, than someone who's got a severe brain injury. So anything we can do to look at, and I think this is where pupillometry comes in, because it's non-invasive. And you will see, as I said, the pupils are nature's own ICP. You'll see changes in velocity constriction. And with the apps and all of that, rather than a pen torch in a brightly lit ED where you can't see the pupils anyway, it's even the subtle changes in constriction will hint at there is someone that's got raised ICP. So it is that, easy to use algorithms, simple tools, and I think pupillometry is one definitely we could use. I think GCS is still a good score, but we've all done GCS on someone who's had a stroke and we're trying to squeeze the plegic side. That doesn't work. They're not going to localize if it's paralyzed. What do you do? Or if English isn't their native language, we've had patients that are M6 in their own language, but confused in English. So it's using other surrogate markers. So I would probably put an MPI. 4 score is again something that's a little bit more looking at pupillometry and a GCS. So putting those two more modalities together probably gives you a better triage.
Brilliant. Yeah, absolutely. And
what you're wanting to do is actually do a scan. And I know CT scans, what you're trying to do is, does this patient need a CT scan now? Can they wait for 6 hours for a scan? Because if you do it now, and there's something you can optimize.
Absolutely. And no, pupillometry, I mean, it seems like it obviously has a massive effect, and definitely a huge indicator in intensive care. So it's definitely something, I'm going to personally read around a lot more as well. And just because I'm aware of your time, I'm just going to keep it to one last question now. But we have a lot of students in the audience, I believe. And what advice would you give to our young budding neurointensivists looking to go into training and stuff like that? What piece of advice do you think would be handy from this early on in their careers?
I'm just going to answer a quick question from Eric. He said,
absolutely.
GCS and pupillometry or GCS and biomarkers. I think biomarkers are a little bit way off. I think you can never have enough modalities. So I would have everything. I'd have the TCD, the pupillometry, the GCS, and a biomarker all on. The more the merrier, because that will give you a better outcome. Biomarkers are a little, if we could get the same point of care as we can for TROPS in A&E, then yeah, we're definitely heading there. So what can I say to budding neurointensivists? One of my daughters is an F2. I haven't convinced her to do neurocritical care, but she wants to do palliative care, which is part of my job as well. That's a big part of neurocritical care, having those conversations. What can you do to intensive care medicine? I'm definitely, I think it's the best speciality, and I am very biased, I'm very partial, but it brings everything for me. So I think if you want a career that's rewarding, medicine is rewarding, but I find the combination of physiology, having a really close working relationship with the neurosurgeons. So neuro ICUs tend to be small, well-contained, everyone in the neuro ICU, but you're part of a huge teaching hospital. So it's a bit like being in a district general, and everyone, all the neurosurgeons, all the neurologists, the scrub staff and the INR staff. I think intensive care gives a lot. You've got that patient communication with families, MDT work. So what can you guys do? Unfortunately, ICM is an ST3 level entry post-training program. So how can you get to that ST3? Several routes. You either go through the IMT ACCS route with anaesthetics, or IMT going into it. There are lots of dual training with ICM, and that's a popular one. It is a little bit longer in training because you end up doing 2 sets of exams, one for your base speciality and one for ICM. It is worth it. It's an extra 18 months, but what it gives you as a career is flexibility, because as you see, I've got an interest in point of care ultrasound. I've got an interest in leadership, and intensive care. Although you get a lot of on calls all at one go, I do 1 week of intensive care, and actually I get 3 weeks to do whatever I like, which is come and talk to you guys and convince you all to be neurointensivists so I can retire eventually, and talk about brain injury and be an advocate for improving brain injury treatment across the UK. So I would definitely look at going in through anaesthetics, IMT, the NAC Society, Neuro Anaesthetics and Critical Care Society, is a really good resource. Membership is £10 for students and medical students. They have great webinars, great CPD days, and a really good educational scientific meeting. There's that's a way into, because you'll be surrounded by people in neurocritical care and neuroanesthesia and have what's up to date that's coming there. The big neuroscience centres have always got lots of research on. So if you're interested, reach out to the neuroscience centres and be part of the research, because that's where we're focusing. We're focusing on, because we haven't been part of trials, is actually working collaboratively with other neuro ICUs here and in Europe. And the more people that can help us get that research out, the better. So training, unfortunately, ST3, become part of NACS, reach out to a neuroscience centre, get involved in neuro research. And obviously with all of you being part of BrainBook, you've already, you're supporting that research and education in neuroscience. And that's really valuable as well. I'm always happy to be contacted. You can come and work, I've got jobs. I usually have 10 jobs every 6 months for neurocritical care. But it's not just the neurocritical care. It gives you really good, good experience all round, because you work with so many people.
Absolutely. No, I think that's such good advice. And even from my experience working in intensive care at St. Peter's, it's a very it's a wide MDT, and you'd be surprised in the morning how there was all sorts of specialties you have. And I think, do you think your experience, your time, let's say, in leadership and all the kind of accolades you've got in that, and the experience you've had outside of medicine in building that skill, do you think that's something that's really helped you to become that leader that you are today at Queen Square and in intensive care?
I've got a long way to go before I got a bigger leader. That's very kind, but I think, yeah, very much so. I think, it's part of leadership in intensive care is actually, I'm quite a relational person, and I think it is having good relations. I know my team, I know all my neurosurgeons, and because it is such a lovely small unit, people can come in. So I have neurosurgeons coming into my office, one because I haven't eaten and they know I have a bar of chocolate normally, but also coming in for advice, and I think that is great. So I think I approach leadership very much how I how I approach everything in life, in that being authentic, being approachable, and being part of a team. There's no hierarchy in neurocritical care, because we do rely on the experience of everyone. Everyone's got a voice in neurocritical care. So we've got really experienced speech and language therapists, really experienced physios, psychologists, clinical psychologists. There's a huge bit of work on that dysexecutive syndrome, because the TBI might have recovered, but they're frustrated at home, and they just need to be given tools to be able to do 2 things at once and not get frustrated. So there's just lots of exciting stuff. But leadership, I think you do get in intensive care, because you deal with so many stakeholders. So the medics, the surgeons, stroke physicians, business managers, because it's an expensive resource, intensive care. So, it's the heart of a hospital. If you don't have critical care beds, you're having to turn away people, but we don't turn away people because we find a way around it.
Amazing, absolutely. And it's such a good way to end. And we are aware of time, so we'll end it there. But I don't think we have any more questions. But it's been an absolute privilege to speak with you today, Dr. Waraich. I think we've all learned a lot, and I think we're all going to take a lot away from this talk. And I have to say, we'll be more than happy to welcome you back to BrainBook. And also, you're welcome to St. Peter's. I think we can do with some of your expertise over there. It'd be really nice actually for you, even if you wanted to do some talks in the Surrey hospitals, because I think there's so much to be learned. And I've seen firsthand how much intensive care can change people's lives, and people come in with single-digit GCS and they are honestly back on their, well, I say back on their feet, but walking on the unit. It's incredible to see that rehab process, and you guys are really at the forefront of that. So it's incredible to speak with you guys and learn from you. So that's all I have to add. But we'd love to have you back, and it's been great to speak to you today. And if there's no more questions, then we'll leave it at that.
Thank you so much for inviting me. I've really enjoyed it, and I thank you again. It was I accepted the invitation sort of really excitedly, because I love talking about this. And if I can, as I said at the beginning, if it's through education is the way that we improve neuroscience in the UK and outcomes for our patients. But thank you so much. I do have point. I'm not plugging my point of care ultrasound course, but the accreditation is a UK accreditation course, and it's a skill. So yeah, please, if you have any questions, I put my Twitter handle on there. If you've got questions, please do drop me a post or an email. I'm happy to reply.
Amazing. I'll definitely be interested with working in the future. Even some of the projects we have in neurosurgery, I think I'd be delighted to work on something with you as well. But yeah, the Fusic Brain, you'll see an email coming from me soon. That's definitely something I'm gonna. No, absolutely, it's definitely something I'm gonna get onto. I think it's such an interesting thing to get involved in. So just keep an eye on my email.
I will do.
But if there's nothing left, yeah, I mean, there's a whole host of thank yous in the chat. Thanks, guys, for joining.
Thank you.
And thank you for your attention. And yeah, thank you as well to you, Dr. Waraich. And if there's nothing left to be said, then I'll see you very soon. And I hope to work with you in the future, actually.
I look forward to working with you as well. Thank you, everyone, for your time and patience.
Thanks so much, guys.
Bye.
Thanks. Bye.